today we are going to see about the instability of the shoulder joint. This is the part 2 video of the shoulder instability. And when you think about the degree of instability, instability can be divided according to the degree into two categories. That is dislocations and subluxations. Dislocation means the head of the humerus is moving totally out of the glenoid fossa, and subluxation means the head of the humerus is partially out of the glenoid fossa. So that's how instability can be divided according to its degree. Then again, instability can be divided into three different categories according to the direction of the instability. So according to the direction of instability, the shoulder dislocations can be divided into the anterior dislocations, the posterior dislocation, and the inferior dislocations. Of these three, anterior dislocation is the most common type of dislocation. Okay, and inferior dislocation, as I told in the static stability of the shoulder joint, mainly seen in the stroke patients when there is paralysis. Mainly the head of the humerus moves out of the glenoid cavity. And what are the mechanism of dislocation, shoulder dislocations? So first let us see what is the mechanism of injury in anterior dislocation. So anterior dislocation, the mechanism of injury is mainly due to an abduction as well as an external rotation force. An abduction as well as an external rotation force. The mechanism of injury is by an abduction as well as an external rotation force. So let us biomechanically analyze how this abduction and external rotation causes anterior dislocation. So when you are going for external rotation, what is the arthrokinematic movement during external rotation? The arthrokinematic movement during external rotation is the anterior rolling of the head of the humerus within the glenoid fossa. The head of the humerus is moving anteriorly. So external rotation is the anterior movement of the head of the humerus. And what is the arthrokinematic movement during abduction? The arthrokinematic movement during abduction is the inferior rolling of the head of the humerus. So when the head of the humerus moves inferiorly and anteriorly, and when there is a force acting in this direction, what happens? The head of the humerus moves down as well as anteriorly, result in the anterior dislocation of the humerus. Okay, now let us see in deep into the anterior dislocation. Okay, so the mechanism of injury is an abduction and external rotation force. And have you ever heard about unhappy triad? You might be knowing in the knee joint. What is unhappy triad at the knee joint? Unhappy triad at the knee joint. When there is a valgus force occurring at the knee joint, what are the injuries happen when there is a valgus force? When there is a valgus force occurs at the knee joint, there is an injury to the anterior cruciate ligament, the medial collateral ligament, as well as the medial meniscus. And these three injuries is combined together to form the unhappy triad. When there is a valgus force at the knee joint, there is an injury occurs to the anterior cruciate ligament, medial collateral ligament, as well as the anterior meniscus. This is called the unhappy triad at the knee joint. Same like the unhappy triad at the knee joint, there is also an unhappy triad occurring at the shoulder joint when there is an anterior dislocation. when there is an anterior dislocation at the shoulder joint? What is that unhappy triad at the shoulder joint? So when there is an anterior dislocation, what happens is that there will be an injury occurring at the rotator cuff muscle. There is an injury occurring at the rotator cuff muscle, as well as there is an injury occurring to the axillary nerve. And these three injuries, anterior dislocation associated with rotator cuff injuries, associated with axillary nerve injury, is known as the unhappy triad at the shoulder joint. So very, very important. Unhappy triad at the shoulder joint is the anterior shoulder dislocation associated with rotator cuff injuries along with axillary nerve injuries. Okay, first let us see what are the complications of anterior dislocations. Okay, so in this video I am trying to explain only the neural as well as the vascular complications arises from the anterior shoulder dislocation. This is because as a therapist we need to know two basic things. One is a thorough knowledge about the anatomy, and second one a thorough knowledge regarding the biomechanics. Okay, and while knowing the biomechanics, we help us to know about the mechanism of injury, and doing the anatomy we can able to correctly analyze or correctly assess the extent of injury in the patient. So the complication of anterior shoulder dislocation can be divided into three headings, and these classification, the complications of anterior dislocation under three classification. This is my classifications. So these classification you cannot see in any book. So this is the best way to remember the complications of anterior dislocation. So anterior dislocation, I divided into as a neural complication, vascular complication, and structural complication. So what is the neural complication? Neural complication, something regarding with the nerves, mainly the complication, any injury to the brachial plexus or any injury to the axillary nerve. So these complication comes under the neural complication. And what are the vascular stretches? What are the complication when there is an injury to the blood vessels? That's a vascular complication. So when there is an anterior dislocation, there can be an injury to the axillary artery. What are the structural complications? So structural complication I divided into two separate headings. One is the soft tissue structural complication, and other is the hard tissue structural complication. So the soft tissue structural complications are the Bankhart's lesions, the slap injuries, the rotator cuff injuries, and the injury to the ligaments and the joint capsule. And what is the hard tissue complication? Hard tissue complication is the Hill-Sachs lesion. Okay, so I'll just give a rough idea about the structural soft tissue complication. So what is Bankhart's lesions and slap lesions? So Bankhart's lesions and slap lesions are actually an injury to the glenoid labrum. So in Bankhart's lesion, there is an injury to the anterior inferior aspect of the glenoid labrum. Okay, anterior inferior aspect of the glenoid labrum. And what is a slap lesion? What is the full form of slap? Superior labrum anterior to posterior. So there is a labral injury on the superior labrum from the anterior to the posterior aspect of the labrum. That is called the slap lesion. And of course, there is a rotator cuff injury, and there can be ligament injury to the ligaments as well as the joint capsule. So these structural complications I am going to explain in detail in my next video. And what is the hard tissue complication? Hill-Sachs lesion. What do you mean by hard tissue complication? Hard tissue complication is nothing but the complication happening to the bones. What is Hill-Sachs lesions? So as you know, when there is an anterior dislocation, so imagine this is the This is the glenoid cavity. So the glenoid cavity, the head of the humerus is moving anteriorly. Okay, the head of the humerus is moving anteriorly, inferiorly, and so inferiorly, head of the humerus moves inferiorly and anteriorly. So what happens? So this is the anterior aspect of the humerus, and this is the posterior aspect of the humerus, and this is the medial aspect, and this is the lateral aspect of the humerus. So when the humerus moves inferiorly and anteriorly, what happened to the head of the humerus? The head of the humerus will make contact with the anterior inferior aspect of the glenoid labrum. Which part of the humerus make contact with the anterior inferior aspect of the glenoid fossa? The posterior lateral aspect. The posterior lateral aspect of the humerus head will make a contact with the anterior inferior aspect of the glenoid fossa. Okay, the posterior lateral aspect. So what happened is that because of that injury, because of the inferior as well as anterior aspect of injury, the anterior inferior aspect of, so this is the anterior inferior aspect of the glenoid fossa, and these humeral posterior lateral aspect of the humerus will make a contact with the anterior inferior aspect of the glenoid fossa, which can result in an indentation fracture of the head or posterior lateral aspect of the humerus, because the posterior lateral of the humerus will make a forceful contact with the anterior inferior rim of the glenoid fossa, which can result in an indentation fracture of the posterior lateral aspect of the head of the humerus due to anterior dislocation, which can result in the Hill-Sachs lesion. So the structural complications need to be explained in detail. So that I'll cover in my next video. Now let us see about the neural as well as the vascular complications. Neural as well as the vascular complications. So let me erase these structural complications. So when I say about the neural complication, I told about the brachial plexus. So when you say about the brachial plexus, you should know the basic idea, basic anatomy of the brachial plexus. So how the brachial plexus looks like. So this is the diagram which I studied in 1993 when I studied in my anatomy. So the brachial plexus has got roots. So C5, C6, C7, C8 and T1. Okay, this is the root of the brachial plexus. Root of the brachial plexus. So I made a mnemonic to remember the brachial plexus. Real tigers can bark. So the real tigers can bark. So take R from the real, T from the tiger, C from can and B from bark. So what does it mean? I'll explain. So root of the brachial plexus forms by the C5, C6, C7, C8 and T1. And C5 and C6 combines together and C7 stands by himself and C8 and T1 again forms pairs. C5, C6 forming pairs, C7 stands by himself and C8, T1 forms the another pair. Okay, so these are the C5, C6, C7, C8, T1. These are the roots of the brachial plexus. So that is the real R, roots. Next, the tiger, T. Next comes the trunk of the brachial plexus. The trunk of the brachial plexus. Here comes the trunk of the brachial plexus, which is marked in red. The trunk of the brachial plexus. the trunk of the brachial plexus. So these C5, C6 nerve roots forms the superior trunk of the brachial plexus. The C7 forms the middle trunk of the brachial plexus, and C8, T1 forms the inferior trunk of the brachial plexus. The superior trunk, the middle trunk, as well as the inferior trunk of the brachial plexus. From the trunk forms the cord of the brachial plexus. From the trunks form the cord of the brachial plexus. The cord of the brachial plexus. The superior trunk continues as the lateral cord of the brachial plexus. The middle trunk continues as the posterior cord of the brachial plexus, and the inferior trunk continues as the medial cord of the brachial plexus. Okay, and this is the cord of the brachial plexus. Cord of the brachial plexus. From cord, we are moving to the trunk of the branches of the brachial plexus. The lateral cord continues to form the branch of the brachial plexus. Okay, the branch, first one is the musculocutaneous nerve. Okay, the musculocutaneous nerve, and from the lateral cord of the brachial plexus, and from the medial cord of the brachial plexus forms the medial nerve, the median nerve. Okay, and the posterior cord of the brachial plexus, continues to form mainly two branches. One is the axillary nerve, and the other one is the radial nerve. Okay, and the medial cord alone will form the ulnar nerve. Okay, so the brachial plexus branches are the musculocutaneous nerve, which is formed only by the lateral cord of the brachial plexus. The posterior cord combines to form the axillary as well as the radial nerve, and the lateral cord as well as the medial cord combines to form the medial nerve, and the medial cord continues to form the ulnar nerve. So all these 1, 2, 3, 4, 5 branches. Okay, and again the posterior the middle trunk has got connection with the lateral as well as the medial one. Okay, again from the posterior cord, again there is a connection to the superior trunk of the brachial plexus. So this is the brachial plexus. So here you can see the root is formed by C5, C6, C7, C8 and T1. Okay, and where you can see the root of the brachial plexus. Root of the brachial plexus is seen at the neck level. Root can be seen at the neck level. From there, the trunk arises, where you can see the trunk of the brachial plexus. Where you can see the trunk is seen at the interscalene triangle. So where you can see the interscalene, if you turn your neck, this is the sternocleidomastoid, and the lateral muscles of the neck is known as the scalene muscle, and the interscalene triangle is seen between the scalene anterior as well as this middle scalene. This is the interscalene triangle, and the interscalene triangle is also called as the supraclavicular fossa. And the trunk of the brachial plexus location of the trunk of the brachial plexus is at the interscalenar triangle or at the supraclavicular fossa. And where you can see the cord of the brachial plexus, brachial plexus, just below the clavicle. The cord of the brachial plexus is seen below the clavicle, and where you can see the branches at the level of the axilla. So this diagram, remember this diagram, very simple. C5, C6, C7, C8, T form the root of the brachial plexus. C5, C6 combine to form the superior trunk. C7 forms the middle trunk, and C8, T1 form the inferior trunk of the brachial plexus. For the superior trunk will continues as the lateral cord of the brachial plexus, and the middle trunk continues as the posterior cord of the brachial plexus, and inferior trunk continues as the medial cord of the brachial plexus. From the lateral cord of the brachial plexus arises the musculocutaneous nerve. And what are the muscles supplied by the musculocutaneous nerve? We'll come in detail about these nerves once I come to the elbow joint and the wrist joint. So mainly the BBC, the musculocutaneous nerve supplies BBC. What do you mean by BBC muscle? Biceps brachialis and coracobrachialis. Musculocutaneous nerve, BBC. Musculocutaneous nerve, BBC. Okay, so that is the musculocutaneous nerve, and and again the lateral cord as well as the medial cord combine to form the median nerve, and again the posterior cord continues to form the axillary as well as the radial nerve. Again the medial cord alone will form the ulnar nerve. So here comes how the brachial plexus are getting injured. So when the shoulder moves anteriorly, in case of anterior dislocation, there can be a chances of injury to the brachial plexus, especially to the posterior cord of the brachial plexus, because imagine what will happen to the posterior cord. The posterior cord will become stretched because it is seen at the posteriorly. The posterior cord becomes stretched when the shoulder moves anteriorly. So whenever there is an anterior dislocation, there is a overstretching of the posterior cord, which can result in the injury to the posterior cord of the, especially to the posterior cord of the brachial plexus. And again, there can be injury to the axillary nerve. So axillary nerve root value is C5, C6. So the axillary nerve, it passes from the axilla and it winds round the surgical neck of the humerus. It winds round the surgical neck. Here you can see, this is the surgical neck. The green marking is the surgical. So it winds round the surgical neck. It winds around the surgical neck of the humerus. It winds around the surgical neck of the humerus. So when the shoulder moves anteriorly, what happens? This nerve is getting stretched and cause injury because it winds around the surgical neck of the humerus. When the shoulder is moving anteriorly, it can stretch, it can pull, and this distraction force can cause an injury to the the axillary nerve. And the axillary nerve actually gives three branches: an anterior branch which supplies to the anterior aspect of the deltoid, and you have a posterior branch which supplies the posterior aspect of the deltoid as well as the teres minor. And it has got a third branch is called the articular branch, which supplies at the glenohumeral joint itself. Okay, and this axillary nerve supplies mainly to the deltoid as well as to the teres minor. So whenever there is an injury to the axillary nerve, you have to suspect any weakness of the deltoid as well as the teres minor muscle. So when there is weakness or when there is paralysis of the deltoid, what you can expect in the shoulder joint? What range of motion is affected? The range of motion affected is the shoulder abduction, especially from 15 to 90 degrees of shoulder abduction. 15 to 90 degrees, because 0 to 15 is done by the supraspinatus muscle. 0 to 15 is done by supraspinatus, and 15 to 90 degrees is done by the deltoid muscle. So whenever there is any axillary nerve injuries, think of deltoid paralysis, and the affecting range of abduction is 15 to 90 degrees of shoulder abduction. And again, look for any weakness of teres minor. What is the action of the teres minor? Lateral rotation of the shoulder. And look for any lateral rotation weakness, and mainly you cannot see that much weakness of the lateral rotation because infraspinatus also provides lateral rotation. So a minimal lateral rotation is affected because of the injury to the teres minor, because lateral rotation is a combined action of teres minor and infraspinatus. And again, this axillary nerve is more prone to injury when you are using the crutches. That will come to, and that I will explain when I am explaining about the crutches, axillary nerve. And again, when there is an axillary nerve injury, there can be injury or the paralysis of the deltoid muscles and the teres minor. So, 15 to 90 degrees of abduction is affected, and there can be a flat shoulder, because since the deltoid is the muscle which gives the bulkiness of the shoulder. Since the deltoid is paralyzed, you can get a flat shoulder. Okay, that's about the axillary nerve injury. And when you think about the brachial plexus, think of these mnemonics. This is the mnemonics I made. Real tigers can bark. What do you mean by that? Real means root. Okay, tiger means trunk, can means cord, and branch means bark. So real tigers can bark means real, root of the brachial plexus, C5, C6. Tigers, trunk of the brachial plexus, superior, middle, and the inferior trunk of the brachial plexus. Real tigers can bark, the cord of the brachial plexus, the lateral cord, posterior cord, as well as the medial cord of the brachial plexus, and bark, the branches, the musculocutaneous nerve, the axillary nerve, as well as the radial nerve, the median nerve, and the ulnar nerve. So you can make your own mnemonics. So this is the mnemonics I made. The real tigers can bark, which you can when you think about the brachial plexus. And next, let us come to the vascular causes. Come to the vascular causes. So when you come to the vascular causes, so which is the, what do you mean by the vascular causes? Vascular causes are the, when there is any injury to the blood vessels. Any injury to the blood vessels, either to the arteries or the veins. The axillary artery. So what do you mean by the axillary artery? So the axillary artery is one of the largest artery which supplies the lateral aspect of the trunk. The lateral aspect of the trunk, okay, the axilla as well as to the upper limb. Okay, so it is the artery which supplies the lateral aspect of the thorax, the axilla as well as the upper limb. So from where this axillary artery arises? The axillary artery arises from the subclavian artery. Imagine. So I'll give you a very rough idea regarding the circulations. Okay, so imagine which is the largest artery in the body. Aorta is the largest artery. So where you can see the aorta? You can see at the left ventricle. So from the aorta arises from the left ventricle, which will supply oxygenated blood to all the system of the body. Okay, and this aorta, so this aorta, so this is just the heart, so arises from the left ventricle. So this is the aorta. So here this is called the arch of the aorta. Okay, and from the arch of aorta there arises mainly two important arteries. One is the subclavian artery, and other one is the carotid artery. The carotid artery. So what do you mean by the carotid artery? The carotid artery is the artery which supplies to the brain, mainly the anterior aspect of the brain. The carotid artery supplies the anterior aspect of the brain, okay, and this subclavian artery, the subclavian artery again moves up and posteriorly, and it continues as the vertebral artery. So two subclavian artery, it moves posteriorly and superiorly, continues as vertebral artery, and the vertebral artery combines to form the basilar artery, which supplies the posterior aspect of the brain. Okay, so the anterior aspect of the brain is supplied by the carotid artery, and the posterior aspect of the brain supplies by the vertebral artery as well as the basilar artery, which arises actually from the subclavian artery. So from the base of the aorta arises the coronary artery, which supplies to the heart. So from the base of the aorta, from the arch of the aorta, carotid artery as well as the subclavian artery. Okay, and I don't want to confuse you. From the left aspect of the arch of aorta arises the subclavian artery, and from the right area of the brachiocephalic arteries. Just think like this: from the arch of aorta, carotid artery, which supplies the anterior aspect of the brain, and subclavian artery again arises from the arch of aorta, which continues as the two vertebral artery, and two vertebral artery combines to form the basilar artery, which supplies the posterior cerebral circulation. And from the base of the aorta, the coronary artery, which supplies to the heart. Okay, so actually I already finished a book of neurology where I very simplified the basic neuroanatomy. The neuroanatomy, the central nervous system, the peripheral nervous system, the autonomous nervous system, the cranial nerves, and the parts of the brain and its function. And I am having some negotiations with the publisher in India. If everything goes well, I can publish that book by the mid of next year. Okay, that is a very simplified book where I explain everything basic what a healthcare professional need, mainly for the physiotherapists, nurses, pharmacists, occupational therapists, etc. Okay, and coming to the axillary artery. So the axillary artery arises from the subclavian artery. So the subclavian artery posterior superiorly, it continues as a vertebral artery, and the subclavian artery comes down and continues as the axillary artery. From where? So the axillary artery originated from the lateral aspect of the first rib. Till the lateral aspect of the first rib, it is called as the subclavian artery. Till the lateral aspect of the first rib, it is called as the subclavian artery. From the lateral aspect of the first rib, where you can see the first rib just below the clavicle, from the lateral aspect of the first rib, it continues as the axillary artery. And again, this axillary artery moves down and continues as the brachial artery. Once it crosses the inferior border of the teres major muscle, it continues as the brachial artery. Okay, what is the importance of the axillary artery? The axillary artery has got 6 branches. 6 branches. So how, and there is a interesting mnemonic in order to remember the 6 branches of the axillary artery. That is cystis, teen, love, sex, and port. Cystis, teen, loves, sex, and port. This is the branches of axillary artery. What is cystis, teen, love, sex, and port? This is a mnemonic. So there are different types of mnemonics. So when you think of some naughty mnemonic or some crazy mnemonic, you will remember, right? So sex and port, People will remember. So what is cysteine, Slough, section pod? So it has got 6 branches. 1, 2, 3, 4, 5 and 6. Injury. What is ACAP? AC, air condition. What do you mean by air condition? It can provide cold. Okay. So any arterial injury, there is the skin is cold. Arterial injury, the skin is cold and there is an absent pulse. AP, absent pulse. Okay. In case of arterial injury, there is a coldness of the skin. The skin is cold and there is an absent pulse. And the skin color is pale. Skin color is pale. And when there is a venous injury, I made a formula. You can use your own formula. Venous with blue sky. My formula is Venus with blue sky. What do you mean by Venus? Venus is the hottest planet. So Venus with warm. Venus is hot. So Venus warm with blue sky. Blue means bluish coloration of the skin and sky is swelling. So these are the features you can see in a patient with venous problem. That is, the skin is warm and there is a bluish coloration of the skin and there is a swelling. So when there is swelling, you can suspect of the pain. But when there is an arterial problem, AC, air conditioner, means there is the skin is cold and AP, absent pulse. So whenever there is any injury to the axillary artery, think of these arterial complications like coldness of the skin, okay, feeble pulse, etc. So that's about the vascular complication arises due to the anterior dislocation of the shoulder. So probably this is a long video. My excuses because I cannot make it as short because you need to have a basic knowledge about the anatomy as well as the biomechanics. Okay, hope you understand the complications of anterior dislocation, the neural complication as well as the vascular complication. The next video is going to be the structural complication where we are going in depth into the Bankard's lesions, slap lesions as well as the Hill-Sachs lesions. Okay, thank you.